So good day everyone. So for this session, we will be tackling the most essential concepts sa ating electrical properties of the heart, particularly yung ating electrocardiogram, yung ating ECG, and yung ating mga cardiac action potentials. Now, as you may already know, ECG is one of the most important concepts, not only in physiology, but in our careers that we will have to study. Ito yung tipong topic na mapapabalik ka talaga sa rason bakit tayo pumasok ng med school. Ito yung tipong topic na never mong matatanong kung gagamitin mo ba ito, hindi. Kasi for sure, we will all be using what we will learn in this topic. And I really put a lot of effort dito sa presentation na to. Although nanguha lang ako dito sa mga references na nandito sa baba. But I organized it in a way na my goal for you after this session is sana right after this session is maalala niyo lahat ng important concepts about ECG until the end of our careers. So for the rest of our careers, it is my sincere hope that we will all be able to still remember and master the most essential concepts pagdating sa ating ECG because this is what makes our hearts beat and what keeps us alive. Diba? So, sige, let's go kasi we have limited time lang. So, tatlong Zoom sessions na yung sinend ko para in case sumabot tayong 2 hours. Diba? Tatlong 40 minutes. Okay, sige, let's go. Focus. So our goal is sana we will be able to understand bakit nagiging ganito yung shape ng electrical activity ng heart natin sa ECG. We have 12 leads here, so we will understand bakit ganyan yung shape nila, yung magnitude, yung amplitude, yung time, yung heart rate, and etc. So at the end, you will be able to understand bakit ganyan itsura nito. So here's our roadmap. As always, we always want to have a map from where we are right now, kung saan, ano yung alam natin, so that hindi tayo maligaw sa patutunguhan nating mga bagong teritoryo, di ba? So we have a roadmap. We start with the conduction system anatomy ng electrical pathways ng heart, and the basic electrophysiology, kung bakit ba naging ganun yung electrical activity ng heart, depolarization, repolarization, the vectors ng electricity, circuits, and etc. And then after that, we'll now be dealing with normal ECG measurement. So now we know kung ano yung normal na dapat na direction ng electrical conductance ng heart. Papanoorin na natin siya ngayon. We will now be viewing it in different directions, in different planes. So yun yung purpose ng ating ECG. Papanoorin natin yung heart kung tama nga ba yung direction ng kanyang electrical conduction. Okay? So papanoorin natin using our ECG, yung basic electrophysiology. And after that, tapos na tayo sa normal, we will be dealing with some basic arrhythmias lang naman. Ito mga tachyarrhythmias natin, bradyarrhythmias, mga pulseless electrical activity, asystole, etc. And lastly, we will now be dealing with paano nga ba na-degenerate itong mga pinapanood natin dito sa ating ECG, itong electrical activity. How is it generated? And it's all because of 3 different types of cardiac action potentials that we will differentiate later on in this presentation. Okay, so we start with conduction system anatomy and basic electrophysiology. So we start first with a brief overview of the relevant anatomy of the heart. So of course, deoxygenated blood from the upper parts of our body go through the superior vena cava, from the inferior part of the body, of course, from our inferior vena cava, and both of them will drain towards our right atrium. Okay, so in our right atrium, it will go to our right ventricle through the tricuspid valve, and then the right ventricle will pump it to the pulmonary arteries, okay, right and left, papunta sa ating lungs to be oxygenated and to offload yung carbon dioxide, di ba? And then, pag na-oxygenate na siya, babalik na siya through our 4 pulmonary veins right here. Okay, the vein is balik to the heart, so babalik siya to the heart. It will go to the left atrium, and then it will go to the oxygenated blood will go to the left ventricle through your mitral valve or your bicuspid valve, and then it will now be pumped through the rest of the body in the systemic circulation through the aorta. Okay? So that's just a brief review of normal heart anatomy, but this is kung ano talaga yung kailangan natin, the conducting system anatomy. So, di ba meron tayo tinatawag na electrical circuits in the heart that allow it to beat spontaneously. So, meaning, di ba, hindi naman natin control voluntarily yung pagbeat ng heart natin. So, it's spontaneously generated itong electrical signals by what we call our pacemaker, primarily our sinoatrial node located in the right atrium. Diba, sinus means a cavity or a sac, so meron siyang space dyan, a cavity, kaya sinoatrial within the right atrium. So sinoatrial node, that's our main pacemaker. It will send electrical signals throughout the atria, And then going to the atrioventricular node, so named kasi it's between your atria and ventricle. So atrioventricular node, andyan siya sa gitna nilang dalawa. Okay? And it will go to your atrioventricular bundle or the bundle of His. So ito yon, which will divide into your right and left bundle branches and will terminate as your Purkinje fibers. Your Purkinje fibers will be the ones who will provide the electrical conduction to your ventricles, to your musculature in your ventricles. So very important yan so that makapag-pump, makapag-contract yung ating ventricles so that they can pump blood to the lungs or to the rest of the body. Okay? So, bakit naging primary pacemaker natin ang sinoatrial node? It's because siya yung may pinakamabilis na or pinakamataas na magsisend ng beats or electrical signals at a rate of 60 to 100 beats per minute. So, di ba yan yung normal heart rate natin? The sinoatrial node provides your spontaneous action potentials at a rate of 60 to 100 beats per minute. Siya yung pinaka-priority, siya yung pinakamalakas sa kanilang lahat na pacemakers natin. Kasi kung titignan nyo, yung ating AV node ay 40 to 60 beats per minute lang. So, na-overcome ng speed ng sinoatrial node yung pace ng AV node. So, nauuna talaga yung sinoatrial node, siya yung priority. So, talagang 60 to 100 beats ang ating normal heart rate. Kung nagkaroon ng problem sa ating sinoatrial node, hindi magkakaroon tayo ng, so mag-take over yung AV node. So 40 to 60 beats per minute lang, that's slow heart rate, that's bradycardia, di ba? And yung pinakamahina nating pacemakers, pwede rin naman sila kung nasira yung sinoatrial node, nasira yung AV node. Meron pa rin naman tayong pacemakers, yung sa Purkinje system, although 30 to 40 beats per minute lang sila. They're very, very slow, very, very weak. Okay? So again, the reason bakit sinoatrial node ang ating main pacemaker, it overcomes all the others kasi siya yung pinakamabilis, pinakamalakas at 60 to 100 beats per minute. Okay? So, bakit natin kailangan balikan to, this excitation, contraction, coupling? Again, excitation, yun yung electrical activity. Diba? That's the electrical signals sent by our pacemakers and conducting cells. So may electrical signals sent there, which will then send action potentials, depolarize the cardiac muscle membrane, diba? Allowing the entry of your calcium sa ating dihydropyridine. Through the dihydropyridine receptors, mag-open yung L-type calcium channels, which will allow calcium to exit from the sarcoplasmic reticulum, causing contraction. So again, this is excitation, electrical, contraction, the mechanical contraction of the heart. Okay? So syempre, it's the contraction of the heart is dependent on these electrical signals sent by our pacemakers and conducting cells, electrical conducting cells. Okay? So, it's very important for us to know kung ano nga ba yung direction ng pag-depolarize or yung pag-send ng electrical signals ng ating sinoatrial node, okay, all throughout the heart. Kasi it's very important na simultaneous mag-beat yung ating mga muscles, okay? And important din na may delay yung pag-beat ng atrium and yung ventricles. Ayaw mo naman na sabay mag-beat yung atrium and ventricles mo. So, paano nga ba kumakalat yung electrical signals from our sinoatrial node, which is located in here, di ba, sa ating right atrium, all throughout the heart. Okay, so we have to know ano yung direction ng circuit, ng electrical circuits natin, electrical activity, paano siya pupunta sa ating, paano siya kumakalat sa ating atrium, paano siya kumakalat sa ating mga ventricles. Okay? So, very important for us to understand yung normal orientation ng heart, okay? Sa ating mediastinum, sa ating thorax, okay? Kung mapapansin nyo, the heart is not diretso lang na ganyan. Di ba? Ganyan, na diretso lang siya, vertically. So, the heart is oriented in this way. Kung mapapansin nyo, it's tilted so much to the nakahiga, para siyang nakahiga na to the left. Diba? To the left, diba? Yung apex is right here, diba? To the left. And it's twisted posteriorly. Para siyang twist, para imagine nyo yung heart, diba? Tilted siya to the left and then twisted posteriorly. Kaya ang nangyari, kung mapapansin nyo, yung right ventricle is found more anteriorly. Ito, yung right ventricle to, kasi itong hati na to separates, di ba? Yung right ventricle and left ventricle. Itong left ventricle, since twisted nga posteriorly, medyo nasa posterior side na siya. Okay? So, yun. So, again, to reiterate, yung orientation ng ating heart sa ating mediastinum, sa ating thorax is parang nakahiga siya and rotated left and posteriorly. Okay? So that, yung apex natin is right about here sa left side, and your right ventricle is now positioned more anteriorly while the left ventricle is positioned more posteriorly. Very important yan when we trace the electrical activity from the sinoatrial node all the way to the ventricular muscles. So, para maintindihan namin to dati, pinagawa kami ni Dr. King ng ganitong model. So, ano ba to? Isang jar. Tapos naglagay kami ng mga hati, which will delineate the four heart chambers. Okay, so kung mapapansin nyo, this is the right atrium, this is the right ventricle, this will be the left atrium, this will be the left ventricle. And then, inask kami na gamitin itong model na to tilt it to the left. So, nakatilt siya to the left ganyan. And, kung mapapansin nyo, nirotate ko siya posteriorly such that the right ventricle is more in front and the left ventricle is more posteriorly. Okay, so I hope magamit nyo tong model na to visualize yung electrical vectors, yung electrical pathways ng ating yung electricity na pupunta nung within our heart. Okay? So, paano na ngayon ang pathway from our sinoatrial node in the right atrium? How can we now do our atrial depolarization? So as we know, di ba, yung depolarization causes contraction. Kasi once you have depolarization, you will have an action potential, mag-open yung dihydropyridine, magpapasok yung calcium, it will lead to contraction. So atria muna tayo. Siyempre, atria muna. Siyempre, doon naman galing talaga yung sinoatrial node. Mauuna talagang ma-depolarize or mabigyan ng electrical signal yung ating atria. So, galing siya sa right. Diba? Galing siya sa right. Okay? Pero syempre, kailangan, hindi lang naman right atrium yung kailangang ma-depolarize. Kailangan pati din yung, sorry, kailangan pati din yung, ah, yan. Kailangan pati din yung ating left atrium. So, yung total vector natin of our depolarization of the entire atria, bakit naging ganito? Inferiorly, leftwards, and posteriorly. So, galing siya sa taas. So, inferiorly, leftward, kasi kailangan din niya i-depolarize yung left atrium. And posteriorly, because again, your heart is twisted posteriorly, your left atrium, tinan nyo to, is positioned more posteriorly. So, para ma-depolarize yung buong atria natin in our atrial depolarization, from our sinoatrial node in the right atrium, it goes inferiorly, leftward, and posteriorly. So ngayon, buong atria na natin yung na-depolarize. Okay? Next. So kailangan so na-depolarize na natin yung atria natin, kailangan na bumalik ng electrical signal ngayon papunta sa septum. Kasi sa septum, 'di ba, andun yung atrioventricular node, andun yung bundle of His and yung bundle branches going to the right and the left ventricle. So kailangan niya bumalik. Okay? So, galing siya dito, nag-inferior, leftward, posteriorly siya, kailangan niya bumalik papuntang septum for our septal depolarization. So, kailangan niya, kung galing siya dito, di ba galing tayo dito, ayan, itong diagram na to, sa model, galing siya left atrium, kailangan niya pumunta dito sa septum, anong gagawin niya? So, kailangan niyang mag-move horizontally lang naman. Dito lang, same plane lang naman, horizontally. Pero rightwards na, again, this is the right side, ha? Ito yung left side. So, rightwards, okay? Rightwards and anteriorly. Kasi babalik na siya doon sa harap ng heart. Galing siya sa likod, di ba? Sa left atrium. Nakalikod yun eh. Nakatwist posteriorly. Babalik na siya ngayon sa septum. So, anteriorly na siya. So, once again, galing siya dito. Atrial depolarization. Babalik na ako ngayon papuntang septum. Okay? So, I go rightwards and anteriorly. Okay? That's septal depolarization. So now, naka-proceed na ako sa aking AV node. I now have to go to my apex of the heart for my apical depolarization. So kailangan ma-depolarize ko na yung apex ng heart, which as we said, since nakapahiga to the left yung heart and twisted posteriorly, kailangan din inferior yung movement ng current, ng electricity, leftward din siya, leftward, and anteriorly. Kasi kung mapapansin niyo to dito sa model, the apex of the heart is also positioned more anterior. Kasi nga, tinwist natin siya posterior. So the apex of the heart will be positioned more anteriorly. Okay? So para ma-depolarize natin yung apex ng ating heart, we go inferior, bababa, leftward, and anteriorly. Okay? Next. Free wall depolarization. Ibig sabihin lang itong free wall, this is the ventricles. Yung muscles natin sa ventricles, sila nga yung main character natin kasi sila yung nagpa-pump, sila yung muscles that allow blood to be pumped to the body or to the lungs, di ba? So ito, yan yung free wall, yan, free wall yan. So, galing tayo sa apex, di ba? Okay, so galing tayo sa apex. So, we depolarize. So, inferiorly ulit. So, inferiorly ulit, leftward ulit, and posteriorly. So, galing tayong apex, galing dito. So, inferior pa. More there. And then leftward and posteriorly. Kasi nga, yung ating left ventricle is positioned more posteriorly. Now, you might be wondering, bakit leftward and posteriorly lang, which denotes our left ventricle lang? Kasi nga, di ba, yung left ventricle natin, for the last time, is position posterior, nasa likod siya, kaya leftward and posteriorly. Bakit yan lang yung kinoconsider nating direction ng electricity? Eh, di ba, syempre, free wall din naman yung kabila, yung right ventricle. Di ba? Bakit hindi rin dapat inferiorly, rightward, anteriorly? Bakit kasama rin naman to sa na-depolarize? Well, since mas makapal ang ating left ventricle kaysa sa right ventricle, more of the current, the electricity goes there. And the reason bakit mas makapal yung ating left ventricle is, of course, siya yung magpapump ng blood to the rest of the body sa systemic circulation. Kailangan niya i-pump yung blood throughout all the organs in the body. Meanwhile, yung right ventricle, ano lang ba trabaho ng right ventricle? To just pump blood towards the lungs. Tapos yung lungs pa is low resistance, low pressure. So, hindi talaga kailangan ng right ventricle mag-pump as much. Konti lang din yung electricity na pupunta sa kanya. So, syempre, majority of the share ng electricity, okay, goes to the left ventricle na mas makapal since it has to pump blood throughout the body. Okay? So, we say that for the free wall depolarization, what we only consider primarily, is inferiorly, papuntang left ventricle, leftward, again, leftward kasi left ventricle, and posteriorly. Okay? And lastly, syempre, hindi naman pwedeng pump lang ng pump yung heart, puro depolarize lang siya. Kailangan din mag-relax. Kailangan mag-relax ng ventricles so that it can refill with blood for the next contraction para makapag-pump ulit siya. So as we know, again, from cardiac muscles, di ba? Once we repolarize the heart, sinequester na natin yung calcium back to the sarcoplasmic reticulum or palabas ng cell, di ba? Wala nang calcium sa loob ng heart, magre-relax na, repolarize na yung ating ventricles, it will relax, okay? So, syempre, pabalik na siya. That would be superiorly, rightwards, anteriorly. Okay? So, yung direction ng repolarization is just opposite. Kanina, inferior, left, posterior. So, pagpapahinga na siya, repolarization, baliktad. So, superiorly, rightwards, anteriorly. Binaliktad lang. Okay? So, I hope that's clear. So, now we're going to correlate yung direction ng circuits natin papunta sa readings ng ating ECG. Okay? So, di ba, sabi natin, the first step is atrial depolarization. And yung atrial depolarization natin, the electrical signal set by the sinoatrial node for atrial depolarization is seen as what we call the P wave on the ECG. Yan yung pinakaunang bump na makikita nyo sa ECG. That's the P wave. By the way, kaya PQRST to, ang sabi kasi, yun daw yung ginagamit noon for geometry. Diba, kunwari gumagawa ka ng geometrical problems ng unang panahon, corner P, Q, R, S, T, parang ginaya lang nila for the ECG. Hindi daw kasi uso noon yung A, B, C, D, E. Okay? So, mas uso daw yung ganito, P, Q, R, S. Ewan ko ba sa panahon noon. Pero ganyan daw. So, P, Q, R, S, T, namili lang sila ng 5 letters na sunod-sunod. Okay? So, walang meaning yan. Hindi yan acronym or what. Okay? So, P, wave, that's the first wave. Okay? Formed through your atrial depolarization. So, next. So, once na matapos na yung atrial depolarization, we have a gap. Siyempre, kailangan natin ng delay before your atria and your ventricles contract. Hindi pwedeng sabay mag-contract yan. Hindi pwedeng after mo mag-send ng electrical signal dito, may electrical signal din dito. Di sabay sila magko-contract. Di hindi mag-work ng maayos yung heart. Kasi we need the atria to contract first to fill the ventricles with blood and then the ventricles to contract afterwards. 'Di ba? Kapag sabay yan nag-contract, hindi makapag-fill up ng blood yung ventricles. 'Di ba? So, kailangan mauna yung atria bago yung ventricles. So, kailangan natin ng gap. So, kung mapapansin nyo, may zero line tayo dito. Itong flat line lang na to. That's the gap, okay, in between the conduction from the atria to the ventricles. And that is blocked through your AV node. So, may delay dun sa AV node. Para hindi siya diretso pumunta sa ventricles. Okay? Very important yan. Yung delay na yan. And then, we now go to the apical depolarization and then the ventricular depolarization. And yan na yung spike na makikita nyo sa ECG reading. The depolarization of the ventricles. Siyempre, mga ventricles yan, sila yung main contractile units natin. Sila yung pinakamalaking electrical activity dapat. Kasi more electrical activity here means stronger contraction, which is used to pump blood throughout the body. Okay, so siya yung pinaka-sharp, pinakamataas na magnitude, ventricular depolarization. So pag na-depolarize na yung ventricles, ang corresponding na makikita natin sa ECG would be this sharp QRS complex right here. May meaning pa tong Q dito, may meaning pa tong S dito, pero not very important. Pero hindi na masyadong important, just so you know, itong QRS complex natin na sinasabi, yung buong complex na yan, that denotes your ventricular depolarization. And as that is happening, by the way, as that is happening, nagre-relax na yung ating atria, nagre-repolarize na siya. So habang nangyayari ang ventricular depolarization, habang pupunta ng electrical circuit dito para mag-contract siya, nagre-relax na yung atria. Kasi nga sabi natin, dapat habang nagko-contract yung isa, nagre-relax yung isa, bawal sabay silang mag-contract. Okay? And then, ayan na, tapos na yung ventricular depolarization. Ito yung gap dyan. And then lastly, magre-repolarize na yung ventricles, magpapahinga na siya, magre-relax na yung ventricles, and that is your final bump here on your ECG. That is your P wave. Okay? So once again, to review, your P wave is your atrial depolarization. Your QRS, that's your ventricular depolarization. Siya yung spike, siya yung pinakamatangkad kasi ventricles na yan. Sila na dapat yung mabigyan ng malaking electricity kasi sila na yung magko-contract talaga to pump blood throughout the body. And then lastly, the last bump on your ECG is your T wave for your repolarization. So magpapahinga na si ventricle. So this is atrial depolarization, ventricular depolarization, and ventricular repolarization. As you can see, nasaan ngayon si atrial repolarization? Asa na ngayon to? Sa ECG. Asa na ngayon? Makikita ba natin to sa ECG, yung atrial repolarization, yung pagpapahinga or pagre-relax ng atria? Actually, since sabay nangyayari yung atrial repolarization or atrial relaxation sa ventricular depolarization, which is this QRS complex right here, hindi natin siya nakikita, namamask siya. Kumbaga, nakatago siya behind the electrical activity of the atrial repolarization ay na-overwhelm. Natatago siya nitong malakas na ventricular depolarization. Okay? Kasi sabay lang sila nangyayari. Okay? Sige. So once again, P wave. Ano nga ulit ang P wave? That's your atrial depolarization. Your PR interval is the time in between. So, PR interval. So, from P to the QRS complex. O baka tanongin nyo, bakit PR interval? Bakit hindi PQ interval? Kasi not all of our tracings have a Q wave. So, but all of them have an R. Kasi yan, yung ventricular depolarization. Pag nawala yan, hindi yan nag-contract yung ventricle. So, PR interval kasi not all have a Q. So, PR interval is from here, makikita nyo naman, to the QRS complex. It's the time between your atrial depolarization and right before your ventricular depolarization. Okay? Anong importance ng PR interval? That's the gap between when your atria contract and when your ventricles contract. And again, you need that gap para hindi sabay mag-contract ang atria and the ventricles. Very important ang PR interval for that purpose. Next, QRS complex, again, the sharp spike here, ventricular depolarization. Your ST segment, so syempre, trace nyo lang S hanggang T. That's the time after your ventricular depolarization and right before ventricular depolarization. Okay? And ang T wave natin, that's again your ventricular depolarization. Magpapahinga na si ventricles. And ano ba to? QT interval. So, tinan nyo lang, logic lang. Q hanggang T. QT interval, ito yan, itong buong yan. It's the time from your ventricular depolarization hanggang sa ventricular repolarization. So, sinasabi lang na QT interval is the time mula sa nag-pump or nag-contract yung ating ventricle hanggang sa pagkatapos mag-relax ng ating ventricle. So, QT interval is ventricular depolarization and ventricular repolarization. Okay? So, nasan ngayon yung atrial repolarization? Saan nga? Nakatago behind the QRS complex. Because atrial repolarization happens at the same time as ventricular depolarization. Okay? So, now we're interested. So now we know kung ano yung electrical activity ng heart, saan pupunta yung mga circuits natin from the sinoatrial node all the way to the ventricles, paano dumadala yung electricity, papanoorin na natin yung electrical activity na yon through the use of our ECG. Okay, so our goal is to be able to view kung tama nga ba yung direction ng electrical signals. Kasi any disturbance sa direction ng electrical signals could be fatal kasi yan ang nagde-determine ng ating pagpump ng heart. Okay? So, how do we view the electrical signals ng heart? Kung napansin nyo kanina, we described yung electrical signals in in three planes. Diba? Inferiorly, leftward, tas posteriorly. Tatlong plane yung ginamit natin, di ba? Just kasi syempre, three-dimensional yung direction ng electrical signal. So, kailangan din natin ng maraming views of the heart using our ECG. And we also can use our planes, okay, sa pag-view ng ating electrical activity sa ating ECG. And so we can use what we call our frontal plane. So frontal plane, parang coronal plane ito. Alam niyo naman yung coronal plane. Ganyan, di ba? And we can also view the heart in the horizontal plane. Papanoorin natin yung heart in this way, in the horizontal plane. Again, frontal plane, papanoorin natin yung heart. Tama ba? Inferior nga ba siya? And in the horizontal plane, tama nga ba? Posteriorly nga ba siya? Diba? So we watch the heart's electrical activity in two planes. Now, ano ba tong limb leads and precordial leads? Ma-meet natin sila. Sila yung mga electrodes na ilalagay natin for us to view the electrical activity of the heart. So again, we watch the heart in two planes, the frontal plane and the horizontal plane right here. Okay? So, for our frontal plane, okay, frontal plane tayo, vertical plane. Okay, frontal plane, we have what we call limb leads or limb electrodes. Itong limb electrodes natin, okay, yan yung gagamitin natin for us to watch the electrical activity of the heart, and ilalagay natin sila sa ating RA, that's the right arm, LA, left arm, LL, the left leg, and RL for the right leg. Technically, ang ginagamit lang natin is these three. Nilalagay natin electrodes here, here, and here. Yan lang yung ginagamit natin to watch the electrical activity of the heart in the frontal plane because the electrode that we put in the right leg is our ground. Meaning, ginaground natin yan so that hindi tayo magkaroon ng disturbances, other circuits, or noise na tinatawag natin sa ating ECG reading. Okay, so para maging clean yung ating ECG recording, we put one electrode sa ground. Okay? So again, for the limb electrodes, we put it in the right arm, left arm, and left leg. Now, sabi natin, we only have 4 electrodes. Technically, yung isa nga is ground. So technically, 3 useful electrodes lang nga. The 3 useful, the right arm, left leg. But in the frontal plane, okay, in the frontal plane, we have what we call 6 frontal leads. Okay? So we have to differentiate leads from electrodes. Yung electrodes, yun nilagay natin yung tatlo. But leads, nakalagay dito, ang definition ng lead are views of the electrical activity of the heart from a particular angle. Okay. So paano tayo ngayon nagkaroon ng 6 na view? Napapanood daw natin yung heart sa 6 na view, pero meron lang tayo kinabit na 3 electrode. It's because we can use these 3 electrodes, okay, and combine them, okay, combine them to produce 6 views. What do I mean? Itong electrode natin sa right arm, this is the left arm, and this is the left leg, it can form a triangle. Pwede natin panoorin yung heart in this direction from the right arm electrode to the left arm electrode. That's one view. We can also use itong view from the right arm electrode to the left leg electrode in this view. This is our second view. And we can also use the view from our left arm, okay, to our left leg. So we can watch the heart in this way. Sana na-gets nyo. Now, we're using combinations of 2 electrodes, Okay? Watching the heart, yung electrical activity ng heart using these two electrodes. Kasi itong electrodes na yan have opposite charges. So current flows from negative to positive. Siyempre, like charges ay opposite charges attract. So pwede natin mapanood yung electrical activity ng heart in this direction, and this direction. Using two electrodes. Using combination of these two electrodes. Okay? These are what we call our bipolar leads. So these are what we call bipolar kasi nga dalawang electrode ginagamit natin. But pwede rin naman nating panoorin yung heart using only one electrode. Kanina dalawang electrode ginamit natin in this direction, pinair natin sila, ganito, tas ganito, to watch the heart. Ngayon, pwede namang from the heart na lang, going to one electrode, from the heart going to another electrode, and from the heart going to the another electrode. So here, isang electrode lang ginagamit natin. We call it unipolar. And we just watch the electrical activity of the heart from one electrode. So sabi natin, di ba, opposite charges dapat. So ginagamit natin na opposite charge is from the heart or from this base right here toward one electrode. That's one view using only one electrode. From here to the left arm, that's another view to another electrode. And from the heart here to our right arm electrode, that's another view. So in essence, meron tayong tatlong electrodes that we can use as bipolar, pinair natin to have 1, 2, 3 views. And we also can use them one by one as unipolar. Tagi-isa lang yung gamit natin. Panoorin natin yung heart, pababa siya, papuntang left arm, and papuntang right arm. Okay? So in essence, using only three functional electrodes, we have 4 leads or 4 views of the heart. 6 views of the heart. 6 views of the heart, 6 leads in the frontal plane. Okay? So bale parang ganyan, ganyan, ganyan. As from the heart, papuntang left leg, left arm, right arm. Okay? 3 electrodes, 6 views or 6 leads. So yan, 6 yung leads natin in the frontal plane. We are watching the heart in the frontal or coronal view. Okay, so we now proceed. So we're done with our frontal plane sa ating mga limbed leads. Okay. So again, we have only 3 functional electrodes with 6 views. Okay, because of what we call the Einthoven's triangle. Siya kasi yung nag-invento niyan. So as you can see, naka-form tayo ng triangle. Yung sides niya, and then from the center going to the vertices. That's Einthoven's triangle. Okay? So now we proceed to the horizontal. So kung kanina, ang view natin sa heart is vertical, frontal. Ngayon, papanoorin na natin ngayon yung heart in the horizontal plane. Like this. Okay? So as you can see, ito muna tignan nyo. As you can see, yes, we're viewing the heart in the horizontal plane. We have 6 electrodes na here. So 1:1 na siya. So 6 electrodes, 6 views, 6 leads din. Okay, so we have V1, V2 hanggang V6. So as you can see, kitang-kita naman na mas malaki yung left ventricle, diba, kaya sa right ventricle, and pinapalibutan natin sila in the horizontal plane pag ano. So as you can see, the most anterior is V1, the most posterior is V6. Very important yan. Diniscuss natin yung direction ng yung orientation ng heart kasi very important yan, di ba? Nasa posterior ang left ventricle, nasa posterior din ang V6. Makikita niya mamaya importance niyan pag nag-check na tayo ng magnitudes nila. So, madali lang tandaan ang placement ng ating what we call precordial leads or leads in our horizontal plane. Yung V1, siya lang yung nag-iisang electrode that we put on the right side of the body in the 4th intercostal space, just to the right of the sternum. And then yung V2, lagay mo lang sa kabilang side niya, partner lang sa 4th intercostal space to the left of the sternum. And then you don't put the V3 electrode first. What you do is you put the V4 electrode first. You put it in the 5th intercostal space, magbilang ka ng 5 space. 1, 2, 3, 4, 5. So lagay mo siya dito. And you put it in one of our landmarks na very, very clear naman na landmark, which is our mid-clavicular line. Mid-clavicular line. Diba? So, ilagay mo siya doon. The reason bakit yan yung uunahin mo, si V4, ilagay mo si V4 bago yung V3, it's because madali lang naman ilagay si V2, to the left lang naman ng sternum sa fourth intercostal space. Madali lang din ilagay si V4 sa fifth intercostal space sa mid-clavicular line. Si V3, ilalagay mo lang siya directly in between them. Okay? Once again, si V3, ilalagay mo lang siya directly in between your V2 and V4. And then si V5 and V6, madali lang din. They have their own landmarks. Fifth intercostal space pa rin. Same line as your V4. Fifth intercostal space pa rin. Pero kung kanina, si V4 is in the mid-clavicular line, si V5 now is in the anterior axillary line. We already studied this in anatomy, bounded by your lower border of your pectoralis major, di ba? And your V6, that's now in your mid-axillary line. So, midpoint ng armpit. So, dito na, sa armpit. Okay, so, still, again, it's in the fifth intercostal space, but si V5 is in the anterior axillary line, si V6 is in the mid-axillary line. Okay, and as you can see, they are watching the heart in the horizontal plane. Pinapalibutan nila. The most anterior again is V1. The most posterior is V6. And as we can see, may importance yan because your vector is directed inferiorly, leftward, and posteriorly. Diba? So now we have a complete view of the heart in the frontal plane by our limb leads. 3 electrodes, 6 views. Kasi kinumbine natin yung dalawang electrode like this, and then like this, and then like this. And then we also have from the heart itself to the vertices. Okay? Using unipolar electrodes lang. Unipolar lang. Isang electrode lang ginagamit natin. For a total of 6 frontal leads and a total of also 6 horizontal leads from V1 to V6. Okay? Now, kung meron mga kayong tatandaan sa presentation na to, I hope you remember this concept. This is the concept of the mean electrical vector. Yan na ngayon yung magdedetermine kung ang tracing sa ECG is pa ganyan, pataas, or pababa, or maliit lang ba na ganon, or malaki bang ganon. Okay? The mean electrical vector. Okay? Sabi dyan, mean electrical vector. Vector just means, di ba, magnitude and direction. Diba? Sa physics, vector has magnitude and direction. Ano daw yung mean? What does mean? Anong meaning ng mean? It's the average. Pag daw kinuha natin yung average ng lahat ng circuits, lahat ng electrical direction ng heart, from the sinoatrial node all the way to your atria to your ventricles, the direction daw is, as I said, inferiorly, leftwards, and posteriorly. I-average daw natin lahat ng sinabi natin kanina, inferior, leftward, posterior, rightward, anterior, basta mga ganon. I-average daw natin lahat ng electrical circuits ng heart. Ano daw yung pinaka ano yung pinaka nakaka-affect ng direction ng electrical activity ng heart? Yung may priority, yung may pinakamalakas na effect sa electrical direction ng conduction ng heart. This one, yun. Inferiorly, leftward, and posteriorly. Again, this is our mean electrical vector. In-average natin lahat, this is what we get. And as we said, diba, the reason for that is yung left ventricle ang may pinakamakapal, pinakakailangan ng electricity kasi siya yung kailangan mag-pump ng malakas to pump blood throughout the rest of the body. Okay? Kapag yung view natin is watching the heart in the same direction as the mean electrical vector, meaning pinapanood natin yung heart. Okay, di ba meron tayong 12 leads kanina? Kapag daw sa mga leads na yon, pinapanood natin yung heart in the same direction. Wait lang. Tapos na daw mag-record yung kanina. Okay. Kapag pinapanood natin yung heart in the same direction as this mean electrical vector of inferior, downward, and posteriorly, okay, it will result in this positive deflection right here. Positive siya pataas. Kapag pinapanood natin yung heart in the opposite direction, the current away from the electrode will result in a tracing that is negative or pabaliktad siya, pababa. Okay? Para maintindihan nyo yan, let's have a concrete example. Let's say lead 1 natin, di ba? Ang lead 1 natin is one of our bipolar leads going from our right arm to our left arm, di ba? That's lead 1. By the way, para maalala na siya, di ba? Parang pag nagbabasa lang naman tayo, we read top to bottom, left to right. So this is lead 1, top to bottom. So dalawang bottom na left. This is lead 2. This is lead 3, left to right. So top to bottom, left to right. So 1, 2, 3. Or counterclockwise. Ayan. 1, 2, 3. Okay, counterclockwise. So this is lead 1 going from right arm to our left arm, di ba? So, we're viewing the heart in this direction. Horizontally leftward lang. Pero, ano yung mean electrical vector natin? Our mean electrical vector is inferior, downward, and inferior, leftward, and posteriorly. So, yung pagnood natin, it's leftward in just the same plane. Okay, hindi naman siya inferior, hindi naman siya posterior, but still, we're following the vector of the heart na pa-left pa rin naman siya. 'Di ba? Our mean electrical vector is inferior leftward. Pinapanood natin yung lead 1 leftward. So, again, same direction yung pagnood natin sa mean electrical vector, it will present with a positive deflection on your ECG. This is lead 1. Paano pag lead 2? Si lead 2 is from our, what is this? Right arm to our left leg. Diba? Diyan natin siya pinapanood. And, kung mapapansin nyo, sobrang parallel niya sa direction ng mean electrical vector. Therefore, you would always expect that the ECG will present with a positive tracing, pataas. Kasi same direction na nga yung pagnood natin sa mean electrical vector. Ngayon, paano na ngayon kapag medyo opposite na yung direction ng mean electrical vector natin sa pagnood natin? Sabi natin, di ba, lead number 3, which is again the third of our bipolar leads, is we watch the heart from our left arm to our left leg. And kung mapapansin nyo, yung direction ng pagnood natin is inferior, pero medyo rightward. Diba? Medyo rightward siya. And ano yung mean electrical vector natin? It's leftward. So medyo taliwas yung direction niya kasi rightward siya. Yung mean electrical vector natin is papuntang left ventricle, leftward. So as you can see here, nakikita nyo, sa lead 3 natin, most often, okay, makikita nyo sa lead 3 is mayroong negative deflection yung ating QRS complex. Diba? QRS complex to. Meron siyang negative deflection kasi opposite yung direction niya to the right. Okay? Pero huwag kayong magugulat kung nakita nyo, lead 3, ito, parang ganito, positive pa rin. It's because inferior pa rin naman. I'm just telling you this na kapag nakita kayo ng negative deflection sa lead 3, okay lang yon, normal pa rin yon kasi, again, to the right siya yung pagnood natin, to the left yung vector ng heart. So both of these are normal, either positive or negative. Depende lang siguro sa placement ng electrodes. Okay? But one distinguishing feature here that I want you to remember is ang QRS complex lang usually ang nagne-negative. Again, for lead 3, which is going to the right pero inferior pa naman, only the QRS complex is usually inverted. Siya lang yung nagne-negative. Usually yung P wave and yung P wave, ito, di ba yung P wave yung pinakauna dyan? Usually yung P wave, positive pa rin naman siya. Why? Kasi inferiorly pa rin naman yung vector natin. Ang nagkatalo lang is either right or left. Okay, so once again, usually only the QRS complex is the one that is inverted. Now for our unipolar, so pag unipolar, di ba isang electrode lang ginagamit natin from the heart going to the 3 electrodes, tagi-isa lang unipolar. You call pala, by the way, you call the one going to your right arm as AVR, augmented vector right. R stands for right, so madali lang tandaan. AVL stands for augmented vector left. So again, to the left arm, madali lang tandaan. And AVF is augmented vector foot. Papuntang paa, of course. So madali lang siya tandaan. Okay? So these are our unipolar, AVR, AVL, AVF. AVR, oh ito na. Tingnan nyo Ano ang natin, mean electrical vector natin? Inferior, leftward, posteriorly. Pero, di ba pinanood natin yung heart sa AVR in this direction? Superior, upward, and right. Di ba? Superior, right, di ba? which is completely opposite of our mean electrical vector. Doon sa right arm nating electrode, yung AVR natin na lead that's completely opposite, di ba? The mean electrical vector. So what would we expect? Kapag opposite yung pagnood natin sa mean electrical vector ng heart, your ECG will present with negative deflections. So pababa siya. Di ba? Kita niyo yan? Yung P wave is negative, the QRS complex is negative, the T wave is negative. Because everything is opposite the mean electrical vector. So I hope na kita niyo yun, opposite siya lahat, kaya negative lahat. Meanwhile, si AVL, well, pataas siya, pero to the left pa rin naman. So, parang ano siya, nalito siya. Dapat pababa, di ba, yung mean electrical vector natin. Siya, pataas. Pero parehas naman sila to the left. Kaya kung mapapansin nyo, medyo nalito siya. Meron siyang positive. Tapos meron din siyang negative. Di ba? Yan, okay lang yan. Normal lang yan. Okay? Basta ang important lang talaga dito is yung AVR is all of the time dapat negative yan lahat. Okay? And then yung AVF natin going to the foot, which is inferiorly, which is in the same direction naman as our mean electrical vector, we can expect a positive QRS complex. Okay. Paano na ngayon yung ating, so kanina we dealt with the frontal leads in the frontal plane. We now going to watch the heart in the horizontal plane. Okay? So, yan, no? Kung mapapansin ito, schematic dito, we're watching the heart in the horizontal plane, V1 until V6. Okay? So, sabi natin, okay, ang mean electrical vector natin is inferior, leftward, and posteriorly. So, bakit ko sinabi kanina na important malaman na ang V6 is the most posterior? It's because siya yung pinaka nakakapanood ng heart in the most correct direction as the mean electrical vector. Diba? Ang mean electrical vector natin is inferior, leftward, and posterior. Ang pinaka-direct in line to that mean electrical vector is electrode V6. Meaning, the most positive QRS complex should be at V6. And kung mapapansin nyo, yes, we do indeed have a very, very sharply positive QRS complex kay V6. Kasi siya yung pinaka-inline sa mean electrical vector na inferior, left, and posteriorly. Siya yung pinaka-nakakapanood ng heart in the correct direction. Okay? And kung mapapansin nyo, ano mapapansin nyo kay V1? Bakit parang predominant yung negative deflection ni V1? Kasi andito siya, oh. Kita nyo to, andito siya. Nasa right side siya ng heart and medyo anterior pa nga siya. Diba? Which is opposite our mean electrical vector. Diba? Kaya si V1 is medyo negative deflection pa siya. Si V2, medyo may positive na, may negative pa rin. Si V3, medyo hati na siya. Kasi si V3 is this one, diba? Medyo malapit na siya sa heart. So, medyo may positive na, medyo may negative pa rin. Ang gusto ko lang malaman nyo dito, as you go from V1 up to V6, the positivity, okay, of the QRS, the sharpness of my QRS complex increases. Because the more na lumalapit yung mean electrical vector ko sa view ng heart ng V6. Okay, that's why my V6 has the sharpest, most positive QRS complex. Siya yung pinakatugma sa mean electrical vector. So now we have a complete view of the heart in the frontal plane and in the horizontal plane. We have our 6-limb leads, 1, 2, 3, bipolar, AVR, AVL, AVF, unipolar, and our 6 horizontal leads. And that's very important because a 12-lead ECG will give us each individual lead, 1 to 12, will give us individual pieces of the puzzle. And watching all 12 pieces and having all 12 pieces of the puzzle will allow us to have a complete picture. Diba? Finishing this puzzle will allow us to have a complete picture of the electrical activity of the heart. So through those 12 leads, each individual lead a puzzle piece. Kapag na-complete na natin yung puzzle, we will now have a complete view of the electrical activity of the heart, both in the frontal plane and in the horizontal plane. So yan yung importance. Bakit tayo merong 12 ECG leads? So I hope you're now able to appreciate bakit 12 kailangan natin. We want to be able to watch the heart in all these directions because kapag may abnormality sa direction ng conduction ng electricity sa heart, we will have a problem. Okay? So, question 1. Draw the sequence and direction of depolarization from the SA node till the ventricular free wall. I think yun na yung mga binigay ko kanina. Inferior, left, posterior. Kaya na yun. I think very understandable naman. Give the physiological basis for the difference in the recording of leads AVR and AVF. That's our unipolar leads going here and going here. AVR is primarily negative. Why? Because it is opposite the direction of our mean electrical vector. Why is AVF predominantly positive? It's because it's in the same direction, in line with our mean electrical vector, inferior, leftward, posteriorly. Okay? So now we proceed to our second component of our roadmap, normal ECG measurement. So paano na tayong magbabasa ngayon? How do we interpret ECGs? So ito yung ECG strip natin. Okay? Dito muna tayo. In the x-axis, we're measuring time. Meaning, heart rate. Okay? And then in the y-axis, we're measuring magnitude. So, gaano kalakas yung depolarization. Okay? Gaano kalakas yung contraction in extension. Okay? So, again, in the x-axis, we're measuring the heart rate for one small box. Itong small box, ito lang. Kita niyo ba itong tinatrace ko? Sana nakita niyo yung tinatrace ko. That's one small box. That's 0.04 seconds. So in one big box like this, you have 1, 2, 3, 4, 5 small boxes. So in one big box, that's 0.04 times 5, that's 0.2 seconds. So isang ganito daw, that is 0.2 seconds. Again, isang maliit na box, 0.04 seconds. Isang malaking box na ganito, 0.2 seconds. Okay? X-axis for the heart rate. Y-axis for the magnitude, whether positive or negative, depends kung nasa direction siya ng mean electrical vector. So, hindi na siya masyadong important, pero diba sabi natin, V6 dapat ang may pinakamataas na magnitude ng QRS kasi siya yung may pinaka directly in line with the mean electrical vector. So, 1 box daw or 1 millimeter daw, it's 1 millivolt of depolarization. Okay? Pero ang important dito is to remember nyo kung ano ibig sabihin ng 1 box to the right in the x-axis. That's 0.04 seconds. And 1 big box, that's 0.2 seconds. Kasi isang big box may 5 small boxes. Okay, now we have to determine ano yung normal measurements ng ating ECG tracings. For our PR interval, okay? PR interval should be 0.12 to 0.20 seconds. Within that range lang dapat. Kung mas maikli dyan, mas mahaba dyan, probably meron tayong tachycardia or bradycardia. Okay? Or hindi nakakapag-delay yung conduction from the atria to the ventricles, sabay nagko-contract, that's a problem as well. Okay? So the PR interval, 0.12 to 0.20 seconds. So para hindi nyo naisipin yan, isipin nyo lang, the PR interval should be within 1 big box. Kapag within 1 big box siya, normal ang PR interval. Again, the PR interval is from the start of the P wave until the start of the QRS complex. This is the PR interval. Dapat daw within 1 big box siya. Within 1 big box ba to? That's 1 small box, 2, 3, 4.5. Yes, I have 4.5 small boxes. So within 1 big box siya. Normal. How about my QRS complex, my sharp elevation like that? It should be less than 0.12 seconds. Again, kung less than 0.12 seconds siya, dapat within 3 small boxes siya. So kapag si QRS complex ko is placed within 3 small boxes, normal siya. So ito yung QRS complex ko. Kita niyo ba itong tinatrace ko? It's within 1, 2, and 3 small boxes. So normal lang siya. Narrow lang dapat siya. Okay? So again, my PR interval should be within 1 big box. My QRS should be within 3 small boxes. Okay? So, paano natin ngayon i-estimate yung ating heart rate? Okay. So, kanina, we're dealing with seconds, ngayon heart rate na. So, how many beats per minute? So, pwede naman nating i-divide yung distance by the time. Okay, basta. We can use so many calculations to determine the heart rate using yung time and yung distance ng paper in millimeters. Pero we have a shortcut. We have a shortcut here that we can use to estimate heart rate quickly. Ang gagawin natin is we take a complex, a QRS complex that falls on a heavy line. Okay? And then we count kung ilang big boxes ang difference niya to the next QRS complex. Okay? So again, ang gagawin natin ngayon, i-estimate na natin yung heart rate without any calculation. Gagamit tayo ng shortcut. Okay? And what we're going to use is we're going to use ang distance from one QRS complex to the next QRS complex. Okay? So, one big box daw, right after yung isang QRS complex, that's 300 beats per minute. Another big box, that's 150 beats per minute. Another big box, that's 100 beats per minute. And another big box, that's 75 beats per minute. So kung 1, 2, 3, 4 big boxes daw yung difference ng dalawang QRS complex, my heart rate daw is 75. And so these are values that you do indeed have to memorize. Okay? Very important to. Pag na-memorize nyo to, very quick na mag-estimate ng heart rate. Okay? Again, one big box difference, 300 beats per minute. Pangalawa, 150, 100, 75, 60, 50, 40, 30. Noon, ang practice namin dito, paulit-ulit lang, 300, 150, 100, 75, 60, 50, 40. Okay? So, yun. So, pinakamadali, syempre, para ma-estimate nyo yung distance ng dalawang QRS complex, pili na kayo ng QRS that falls sa isang heavy line. Kasi heavy line, it's the delineation of a big box, di ba? So, I'll give you an example. Sige, ako muna. Let's say, this one. So, I choose this. So, anong heart rate nito? Nasa heavy line siya. So, one big box and then another big box. So, that's one big box after. This is 300. Second big box, this is 150. Third big box, this is 100. So most likely, that's my heart rate is between 100 and 150, closer to 150, probably around 140 beats per minute. Okay? Pili tayo ng malinaw. How about, ito, this one. So pipili ako ng QRS complex na nasa heavy line. This is 300, 150, 100, sakto, 75. So my heart rate here is 75 beats per minute. Okay ba yun? Klaro ba? O sige nga, chat box, this one. Ang heavy lines natin dito is this one, this one, this one, this one, this one, and this one. Dito, chat box please. Ano ang heart rate? Okay. $50 daw. Tama ba? Check natin. 300, 150, 100, 75, 60, 50. Indeed, this is 50 beats per minute. Ayos? Nice, nice, nice. Okay, so that's for heart rate measurement. Paano na ngayon? Ang measurement ng normal cardiac axis. So paulit-ulit tayo. It's inferiorly leftward, posteriorly. We need to reiterate this kasi pwedeng magkaroon ng deviations na tinatawag natin from the normal cardiac axis. Kasi kung mapapansin nyo, tingnan talaga yung heart, nakahiga siya to the left, tas twisted posterior. Okay? So, paano na natin ngayon malalaman kung ang axis ng depolarization ng heart, ng electrical signals ng heart, is normal? Normal siya, ayan, no? Inferior leftward, posteriorly. Hanggang dito daw, normal pa naman. Kung yung axis daw ba is RAD or right axis deviation, kasi this is the right side, di ba? Kung paganto daw ba yung electrical signal, or kung todo daw napunta to the left axis deviation, yung ating electrical signal. Okay? Paano natin ngayon malalaman? Using our ECG alone. Okay? The easiest way here, and the classic way talaga, is to look at lead 1 and AVF. Why? Diba si lead 1 natin is this one? From right arm to the left arm. Tama? It's directly in the x-axis. And si lead AVF natin, kung maalala nyo, di ba, pag ganun siya, si lead AVF, from the heart to the foot, it's directly in the y-axis. Para malaman natin yung normal axis ng heart or yung axis ng heart, kukunin lang natin yung area enclosed nung dalawang leads. Ni lead 1 and ni lead AVF. Okay. Baka medyo abstract pa to sa inyo ngayon, pero mamaya magiging klaro to. Si lead 1 kasi nasa x-axis siya, si lead AVF nasa y-axis siya. Kunin nyo lang yung area enclosed ng dalawang yan, this one. Okay? That would tell you kung nasa yung axis ng heart. Kapag si lead 1 mo nandito, si lead AVF mo nandito, ito yung area enclosed, normal ang axis. Paano na ngayon mangyayari kapag right axis and left axis deviation? Ganito yan. Tingnan nyo guys ha. Ano yung normal shape ni lead 1? Ang normal shape ni lead 1, di ba? Ang vector ni lead 1 is paganto, di ba? Ang normal vector ni lead 1 is paganto to the left. And ang mean electrical vector natin is also to the left, so positive. How about si AVF? So this is lead 1. How about si AVF? Si AVF ko is downward, di ba? It's in the same direction as my mean electrical vector then. So dapat si AVF ko is also vertical or positive, pataas. Di ba? So, ang ganito gagawin nyo. Kapag normal si lead 1, papunta siya dito. Kapag normal si AVF, papunta siyang pababa. Di ba? Makes sense. Kasi si lead 1 is from the right arm to the left arm, paganto. Meanwhile, si AVF is from the heart to the foot. Anong ang kukunin natin? The area enclosed by the two axes. Kulayan nyo yan, you will get the axis of the heart. We are within the range of the normal axis. And by the way, shortcut, lead 1, pataas, thumbs up. Lead AVF, pataas, thumbs up. Two thumbs up, all goods, normal axis. Tandaan niyo yan. Next, paano na daw ngayon kung merong right axis deviation ang patient? Meaning, the electrical signal is going to the right instead of to the left. Kailan nangyayari yon? Probably, may right ventricular hypertrophy siya. Kaya yung signal nag-dominate sa right ventricle. Kaya nagkaroon ng right axis deviation. Paano daw natin malalaman na nasa right yung electricity? Kung mapapansin nyo, si lead 1 predominantly is negative, pababa. Meaning, ano bang normal natin? Dapat pataas yan, di ba? Meaning, kung si lead 1 natin ngayon, is pababa and negative, meaning dito siya sa kabilang side. Right. Okay, kita niyo ba itong shade ko? Itong binilogan ko. Ayan ha. Pag ganun siya ngayon, opposite direction, kasi pababa siya eh. Okay? Opposite direction. Pero si AVF natin is normal. Positive deflection, upward. So normal, pababa pa rin siya pag ganun. Okay? Again, anong gagawin natin? Get the area enclosed by the two axes. Si lead AVF natin is normal, so pababa pa rin siya. Si lead 1 natin is inverted. Nasa negative yung deflection niya, o primarily negative yung deflection niya. So dito tayo ngayon sa kabilang side. Kanina, di ba, nandito tayo normal. Ngayon, hindi. Pababa tayo, negative siya eh. So area enclosed nila is this one. And that area is within my right axis deviation. Meaning, the electrical signals are predominantly going to my right ventricle. Okay? Mnemonic. Si lead 1 ko, pababa, thumbs down. Si lead AVF ko, pataas, thumbs up. They are bumping right into each other. Again, si lead 1 ko, pababa, lead AVF ko, pataas. They are bumping right into each other. That's right axis deviation. Okay? Pag nakita niyo pababa si lead 1, nakita niyo pataas si AVF, bumping right into each other, that's right axis deviation. And lastly, kung left axis deviation, si lead 1 is positive deflection, normal. So here pa rin tayo. Kita niyo itong shade ko sa axis, normal, dito pa rin tayo. But si lead AVF ko is inverted, abnormal siya, pababa ang deflection niya, which should not happen. So kanina, normal natin pag ganun pababa. So kung inverted siya, pataas ngayon tayo. So kung pataas ngayon tayo, kasi nga, negative deflection siya, opposite, inverted. So dito siya ngayon sa taas. Ang shaded portion is this one. We now have a left axis deviation. Okay? Normal si lead 1. Ito yan. Tama naman. Pero si AVF, opposite siya. Negative deflection. So pataas ngayon tayo sa y-axis. So shaded area is this one. That's left axis deviation. Okay? Si lead 1, thumbs up, pataas. Lead AVF, thumbs down, pababa. They left each other. Okay? They left each other. Again, si lead 1, pataas. Lead AVF, thumbs down, pababa. They left each other. Okay? Iniwan nila isa't isa. That's left axis deviation. Pag pataas si lead 1, pababa si AVF, they left each other. This is left axis deviation. Okay? And kapag both of them pababa, thumbs down parehas, GG. That's extreme axis deviation, thumbs down, all bad. Okay, that's extreme axis deviation. Yung current ng heart mo papunta, pabalik ng right atrium, that's bad. That's deadly. Okay? So, thumbs down parehas, lead 1 and AVF. Okay? So question 2, given the physiologic basis, why the following ECG changes are seen in patients with right ventricular hypertrophy? Bakit kapag may hypertrophy daw sa right ventricle, bakit nagkakaroon ng right axis deviation? Again, it's because nag-hypertrophy yung right ventricle mo, mas maraming electrical signals pupunta doon, nagkaroon ka na ng right axis deviation. Okay? And right axis deviation is lead 1 is going down, lead AVF is going up, they bump right into each other. Okay. Tall are waves in leads V1 and V2. Oh, bakit daw? Eh, di ba si lead V1 and V2, sila yung pa-right ng heart? Okay? So, kung may right axis deviation ako dahil sa right ventricular hypertrophy, so, ang mapapanood ng V1 and V2 ko is medyo nasa right side sila ng heart, mataas na QRS complex din. Kasi kung ang vector ko is right axis deviation, yung V1 and V2 ko, mataas din kasi nandyan sila sa right side ng heart din. Bakit small na lang yung QRS complex ng V5 and V6? Kasi nandito sila sa likod, nasa left side. Eh di ba sabi natin, may right axis deviation. Opposite na sila ngayon ng vector ko. So maliit na lang yung magiging QRS complex nila. Okay, so I think we can now proceed to the most exciting part of this presentation. So now we'll be learning about your basic arrhythmias. Okay, so now you'll be learning about our basic arrhythmias. You will now be able to read ECGs and be able to diagnose kung ano ibig sabihin ng gantong reading sa ECG. Ito na yung mga nakikita natin sa mga movies. Diba? May V-fib daw. May atrial fibrillation. Mga ganun. Okay. So, ito na yan. Mga basic arrhythmias lang naman itatackle natin. So, for our initial approach, so para organized yung ating tackle or yung atake doon sa ating ECG rate. Is it normal? Check nyo. Ang normal natin is 60 to 100, di ba? So, kung lagpas doon, that's tachycardia. Kung mas mababa doon, that's bradycardia. Okay? Rhythm, di ba? We'll learn a lot about rhythms later on. Tingnan nyo kung may P-wave ba, meaning normal ba yung ating sinoatrial node. Ang QRS ba natin, normal or wide? Mamaya, makikita nyo yung importance niyan. Okay? Pero initially, yes, you would need to have this systematic approach. Pero manasanay na rin kayo tumingin ng mga specific patterns of specific tracings and you will be able to determine the diagnosis very, very quickly na. So, normal sinus rhythm natin, normal sinus, meaning galing sinoatrial node, and normal naman yung rhythm natin, 60 to 100 beats per minute. Meron tayong normal P wave, may normal QRS, may normal T wave. This is a normal sinus rhythm. Heart rate natin is, paano pala kung hindi directly nasa solid line? So, you can pick a QRS complex na nasa gitna. Tapos, pwedeng next box. So, 300, 150, 100, 75, 60. So, it's between 60 and 75. So, we have a normal rhythm here. And then sinus bradycardia, meaning slow heart rate, that's less than 60 per minute. Sinus pa rin naman, sinus rhythm, we still have a P wave, we still have a QRS complex, we still have a T wave. The only difference is medyo mabagal yung pagtibok ng puso. I think we have 300, 150, 100, 75, 60, 50, between 50 and 60. So mas mababa sa 60, that's a bradycardia. Medyo mabagal na yung tibok ng puso. And then pag sinus tachycardia still, sinus rhythm, we still have a P waves, QRS, T. The difference is mabilis siya. So this is 300, 150, 100. So between 100 and 150, greater than 100 beats per minute, that's tachycardia. The heart is beating very quickly. Okay? So, self-assessment, rate and rhythm. So, para mabilis, sige ako na lang. This is, saan ako pwede? Ito. So, 300, 150, 100, 75. So, between 75 and 100, this is normal. How about this? 300, 150, 100, 75, 60, 50. So, between 50 and 60, this is bradycardia. And lastly, here we have 300, 150, 100. So, between 100 and 150. So, this is tachycardia. Lahat naman ba sila? Sinus. I have a P wave, QRST. Meron. Sinus rhythm. I have a P wave, QRST. Normal sinus rhythm. Here, P, QRST. This is normal sinus rhythm. Okay. So now we proceed to tachyarrhythmia. So, mabilis na pagtibok ng puso and sa rhythm, may problem din. So, bukod sa mabilis tumibok yung puso, may problem din sa rhythm mismo. First one is premature atrial contraction or premature atrial complexes, PAC. From the name itself, premature atrial. Ano ibig sabihin nun? Hindi pa dapat mag-beat ng atria, hindi pa dapat mag-depolarize ng atria, nag-depolarize na agad. Excited siya, premature. So kung mapapansin natin dito, PQRST, pahinga, PQRST, pahinga, PQRST, pahinga, PQRST. Hala! Excited! Nag-P-wave ka agad. Premature atrial contraction. Kita niyo ba? Ayan, no? PQRST, di ba? Tapos may pahinga. PQRST. Tapos, walang pahinga. Recta P-wave ka agad. Hindi siya nakapagpahinga. Excited yung atria mag-contract. So, that's what we call premature atrial contraction. Okay, ito na. Atrial fibrillation. This is classically known as yung irregular rhythm. Atrial, meaning yung ano natin, P-wave, depolarization ng atria. Fibrillation, meaning irregular electrical activity. Abnormal, electrical, random, electrical, yan, basta irregular electrical activity. That's what fibrillation means. Kaya kung naririnig nyo, di ba, we have a defibrillator to restore the normal electrical conduction ng heart. Okay? So, kung mapapansin nyo, tinan nyo yung, hindi na nga P-wave ang tawag dito eh. Tinan nyo yung mga waves before the QRS complex. Sobrang irregular, sobrang hindi mo na maintindihan kung anong reading yan. Sobrang irregular. Pag nabasa nyo ito sa kahit anong libro, this is AFib, atrial fibrillation. Tingnan nyo 350 to 600 impulses per minute, sobrang bilis niyan, sobrang irregular pa. Bukod sa mabilis na, irregular pa yung pattern. Tingnan nyo, hindi lang siya mabilis iba-iba pa yung pattern of firing niya. Kaya irregular ang tawag. Irregular na nga siya kasi mabilis. Irregular pa kasi yung mabilis na nga siya pero yung frequency ng bilis iba-iba pa per QRS complex, di ba? So that's what we call irregular atrial fibrillation. Kapag naman atrial flutter, ang characteristic niyan is the sawtooth pattern. Ayan, parang sawtooth. Di ba? Kitang-kita naman. It's because still the atria is beating really fast. Pero, ano naman, atria is beating pretty fast, pero regular naman. Regular. So, as you can see, 1, 2, 3 before a QRS, 1, 2, 3 before a QRS. Di ba dapat 1:1 yan? Isang P, isang QRS. Pero sa kanya, 3 times nag-depolarize yung atria bago mag-depolarize yung ventricle, yung QRS, di ba? So, sobrang bilis ng pag-depolarize ng ating atria. Pero regular, that's atrial flutter. And that's characterized by your sawtooth pattern. Ano ba yung flutter? Di ba yung flutter yung mga ibon? Birds fluttering their wings. Mabilis. Yan, ganyan, di ba? Parang ganyan siya, atrial flutter. Fast pero regular. Okay? So, difference ng atrial fibrillation, atrial flutter. This is fast and irregular. This one is fast and regular. So, kita-kita naman, mabilis pero irregular. Hindi naman pare-parehas yan. Here, pare-parehas lahat. Pero mabilis. So, that's AFib and atrial flutter. Okay? Pag naman, ventricular tachycardia. So, kanina ang tachycardia natin, ang problem nasa atria. Here, ang tachycardia natin, ang problem is nasa supraventricular daw, meaning above the ventricle, probably coming from the AV node. Sobrang lakas ng firing. We have an absent P wave. Kasi nga, absent P wave. So, hindi galing sinoatrial node. Kasi kung galing sinoatrial node yun, dapat may P wave. So, kung absent P wave, probably galing sa AV node. Diba? Sobrang bilis ng firing, nagkaroon ng supraventricular tachycardia. Meron lang tayong QRST, QRST, QRST. Pag nakita kayo ng ganito, na narrow yung QRS niya, ayan, ang payat ng QRS complex, tapos walang P wave, most likely this is SVT, supraventricular tachycardia. Ayan, QRST, walang P wave. Paano malalaman na hindi yan P-wave at T-wave yan? It's because kung nag-ventricular depolarization ka, kailangan may ventricular repolarization ka din. Beat, pahinga. Beat, pahinga. So I am absolutely sure, we should be absolutely sure na T-wave yan. Okay? And this is supraventricular tachycardia. Compare that to what we call ventricular tachycardia. Probably the fast electrical signals here are coming from the ventricle sa Purkinje fibers. Originating from the ventricles at a rapid rate ang ating ventricular tachycardia. How do we differentiate that from our supraventricular tachycardia? Meron tayong wide QRS complex. Di ba? Ito yung QRS, oh. Ang wide. Di ba? Naalala ko to kasi ventricular tachycardia, ventricular or VTAC. Kasi mukha siyang letter V na baliktad, oh, di ba? Ventricular tachycardia. Pag payat, SVT. Supraventricular tachycardia. Ito, pag ganyan na, sobrang wide ng QRS. That's ventricular tachycardia or VTAC. Okay? Ito na, one of the most deadly arrhythmias we have, ventricular fibrillation. Tingnan niyo yung electrical activity sa ventricles. Paulit-ulit, sobrang bilis, sobrang abnormal circuits going on and on in the ventricles, causing massive, irregular, abnormal electrical firing in the ventricles. Look at what happens. Hindi mo na maintindihan kung ano nangyayari. Pag nakita kayo ng ganito na hindi mo na maintindihan kung ano nangyayari, this is VFib already, ventricular fibrillation, and we do need to defibrillate this. Okay? So now we proceed to our bradyarrhythmias. Kung kanina puro mabibilis, now we proceed sa mga mababagal. And kung mabagal, ibig sabihin yan, may blockage, di ba? Sa conduction, di ba? Ang direction natin, sinoatrial node, AV node, bundle of His, tas hanggang sa hanggang sa ventricles, di ba? Kapag merong blockage dyan, kunwari may block dito sa conducting system dito, then probably babagal yung pag-fire, babagal yung pag-beat ng heart kasi may blockage sa electrical conduction system. May barado eh. So babagal talaga yung heart rate. So first degree AV block natin, first degree pa lang, medyo mild pa lang. First degree because the block happens in the atrioventricular node. Probably mabagal yung pag-transmit ng AV node ng electrical signal towards the ventricles. Okay? So kung ganon, di ba sabi natin yung pag-transmit na yon is the PR, di ba? Pag-transmit na signal from the atria to the ventricle, may delay yon. Kapag humaba ng todo yung delay na yon, which is our PR interval, then we have an AV block. Diba? Ano nga importance ng PR interval? It's para hindi sabay mag-beat yung atria and ventricles. Pero pag sobrang humaba na, ibig sabihin, may barado, hindi makadaan yung electrical circuit. Tingnan nyo, sobrang haba ng PR interval. Ano ba yung normal nating PR interval? One big box, di ba? Or 5 small boxes. Sa kanya, tingnan natin from here to here. Basta lagpas na yan ng 1 big box. That's a very, very long PR interval, meaning sobrang bagal ng conduction from the atria to the ventricles. We have an AV block causing slow heart rate. Siyempre, mabagal yung pag-transmit ng electrical signal. Paano naman kung second degree AV block na? Kanina, humaba lang yung PR interval natin. Yun yung first degree, humaba lang yung PR interval. Once we reach a second degree AV block, meron kasing dalawang type yan. But ang common sa kanila, sa second degree AV block, is meron tayong drop beat. What do I mean by a drop beat? Tingnan nyo to. Kita nyo yan? P-wave yan, di ba? May kapartner ba siyang QRS? Wala. That's what we call a drop beat. Ibig sabihin, hindi talaga nakadaan. Hindi talaga nakadaan. Kung wala siyang QRS, hindi talaga nakadaan yung electrical signal papuntang ventricle. Diba? Naiipit talaga siya sa either sa AV node, basta doon sa junction ng atria and ventricles. Diba? Kasi wala akong QRS, hindi nakadaan, hindi nakaabot doon. I had a drop beat here. Why do I have two types? The first type of second degree AV block na may drop beat is what we call my Mobitz type 1 or the Wenckebach phenomenon. Pansinin natin yung PR intervals muna PR intervals. The PR interval here is quite normal. Normal dito. Dito sa pangalawang QRS complex, tingnan niyo yung PR interval. Humaba, di ba? And dito sa pangatlo, tingnan niyo, humaba palalo. And then I had my drop beat right there. Sa Mobitz type 1 second degree AV block, also called my Wenckebach phenomenon, I have progressive prolongation of my PR interval until I drop my QRS complex or my drop beat ako. Okay? Ang mnemonic namin dyan is longer drop. That's a Wenckebach. Okay? That's longer drop. That's a Wenckebach. Tingnan niyo yung PR interval kung pahaba ng pahaba. And then I have a drop beat. That's a Wenckebach phenomenon, Mobitz type 1 second degree AV block. And yung Mobitz type 2 naman na second degree AV block, walang change sa PR interval. Meaning, tingnan nyo yung PR interval nito, normal, 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 PR interval, tapos na drop beat. Hindi humahaba yung PR interval ko, but I still have my drop beat. This is a Mobitz type 2 AV block. Okay? Ito yung comparison ng second degree AV block. Sabi, ang Mobitz type 1 daw, or yung Wenke block, is a block in the AV node. Meanwhile, my Mobitz type 2 daw is a block in the His-Purkinje system. Not very important, pero ito yung important. The progressive prolongation of the PR interval before my drop beat, that's a Wenke block. So, longer na PR interval, drop, that's a Wenke block. And the Mobitz type 2 ko naman, constant lang ang PR interval ko, and then, nagkaroon ako ng drop beat. That's a Mobitz type 2. Okay? And lastly, for our third degree AV block, ito na talaga yung sobrang lala na ng AV block. Ang characteristic shape nito is shark fins. Kung makakita kayo ng shark fins na ganyan, this is a third degree AV block. Walang pakialaman ang P-wave sa QRS complex. Meaning, nag-fire nga yung P, tapos nag-fire din yung QRS, pero hindi sila related. They are firing independently of each other. Kasi dapat dependent yun, di ba? From P, mag-depolarize yung atria and then QRS. Papunta yung electrical, di ba? From the atria to the ventricles, QRS. Di ba? Dapat ganun. Pero ang nangyayari dito, wala silang pakialaman. Nag-fire mag-isa yung P. Wala siyang pakialam. Nag-fire din mag-isa yung QRS ko, yung ventricles ko. Wala rin pakialam. Tingnan nyo tuloy ngayon, yung mga P-wave ko ngayon is unrelated to my QRS. May P-wave dito. Itong QRS na to. May P-wave dito. May P-wave ulit dito. Ito, parang hindi ko alam kung related pa nga yan dito sa QRS na to. Tapos may P-wave ulit dito. Tapos may P-wave ulit dito. Diba? Walang pakialaman ang P-wave sa QRS complex. And when you see shark fins, okay, this is a third degree AV block. Sabi dyan, no? Complete heart block. None of the atrial impulses are able to reach the ventricles. Meaning, sarili nag-fire yung atria, sarili nag-fire yung ventricle, walang pakialaman. That's a third degree AV block, shark fin characteristic shape. And so, try natin to. What type? So, nakita ko na shark fin. This is walang pakialaman, third degree. How about this one? May drop beat ba ako? I have no drop beat, but I have a prolonged PR interval. Ayan, no? More than one big box ang aking PR interval. This is a first degree AV block. How about this one? Oh, I have a drop beat here. Pero yung PR interval ko naman, I don't think na nag-i-increase. So, constant lang ang PR interval ko. Pero may drop beat. This is second degree. Mobitz type 2. Tama? And lastly, for this one, do I have a drop beat? Yes, I have a drop beat right there. Wala siyang ka-partner na QRS. And then, may PR interval ba? Nag-elongate? Yes. Here, humaba, humaba. Okay, again, longer, drop. That's a Wenckebach. So this is second degree, Mobitz type 1, Wenckebach phenomenon. Okay? And then kapag nakita kayo ng gantong vertical line sa ECG, ibig sabihin may pacemaker yung patient. Kapag naman merong electrical activity, pero pwede kasi magkaroon ng electrical activity yung heart. Napapanood natin sa ECG, may electrical activity. Pero nung kinuha niya yung pulse, yung pulso, parang wala namang beat, parang hindi naman nagbe-beat yung heart. That's what we call pulseless electrical activity. Pwede kasi yun. Merong electrical activity pero hindi nagbe-beat yung heart. That's what we call PEA or pulseless electrical activity. Okay? Hindi nagre-respond yung contractile cells, yung muscle cells sa electrical signals. And then yung pinaka-dreaded natin is our asystole, meaning wala na talagang electrical signals firing from our pacemaker cells and our electrical circuits. That's asystole, flatline. Okay? So that's for our basic arrhythmias. We now proceed to our cardiac action potentials. For our cardiac action potentials, we have three. We have our pacemaker cells. Iba yung action potential nila sa conducting cells, meaning yung nagdadala ng, para silang circuits, electrical circuits, wires, na nagdadala ng electricity to the heart muscle. And then yung contracting cells, ito na yung cardiac muscle physiology that we discussed in the first shift. So, ito yung na-discuss na natin. We're done discussing this. Yan yung may, ano, diba? Yan yung may plateau potential. Contracting cells yung muscle. So, ang di-discuss na lang natin is our pacemaker cells and yung conducting cells. So, yung conducting cells natin, sila yung parang wires, sila yung nagdadala ng electricity towards the heart muscles. They are what we call fast response. And kung mapapansin nyo, they look exactly the same as your cardiac muscle, contractile, action potential. Plateau potential pa rin siya. Diba kung naalala nyo yung action potential nung cardiac muscle physiology natin, di ba plateau yun? Parang ito yung muscle cell to mismo. Ito yung parang wires lang, yung conducting na sinasabi natin. Nagko-conduct lang siya ng electricity. Pero same pa rin yung ano niya. Same pa rin yung shape ng kanyang action potential. May plateau pa rin. So same thing. Phase 0 is still the rapid sodium influx. Kaya nga siya fast response. Tingnan nyo naman tong slope na to. At this point, tingnan nyo yung akyat ng action potential. Wala na nga siyang slope eh. At that point, rekta akyat na kaagad ng membrane potential deep. Look at how fast the depolarization is. Vertically, umakyat ang aking membrane potential. Wala man lang ka-bend na ganyan, naka-curve. That's how, kaya tinawag na fast response. Yan, no? So still, it's the same thing. My phase 0, like my cardiac muscle, phase 0 is still my rapid sodium influx. Then, syempre, di ba, it will activate voltage-gated potassium channels. So, it will cause potassium efflux, kaya magre-repolarize. But, anong sabi natin? Ayan, lalabas yung potassium. Pero anong sabi natin? Sa cardiac muscle physiology, may magbabalance na inward calcium. Kasi di ba sa heart, kayang pumasok ng extracellular calcium. Diba? Sa heart muscle, kayang pumasok ng extracellular calcium. So, papasok siya, phase 2. So, habang lumalabas yung potassium, may papasok na calcium. So, lalabas yung positive, may papasok na positive. Nag-cancel out lang. So, nag-balance lang. I have my plateau. Then, eventually, mag-close na yung calcium channels ko. Ang matitirang open would be my potassium channels causing potassium efflux. Magre-repolarize na ulit yung aking heart muscle cell o yung aking conductile cells. Okay? So, ano lang, itong nomenclature lang itong numbering. 0 is the sodium influx, 1 is the short potassium efflux, phase 2 is the plateau, 2 to plateau, and 3 is the repolarization, and 4 is the resting membrane potential. Meanwhile, iba to dun sa pacemakers natin na potential. Bakit kailangan iba yung action potential nila? It's because sila yung automatic na spontaneously nagge-generate ng action potential for the heart. Hindi naman natin control yung pagbeat ng heart. Kaya nilang mag-produce ng sarili nilang electrical signals. So, kakaiba yung kanilang action potential kasi nga kailangan spontaneous sila mag-fire. Okay? So, these pacemaker potentials are different from the action potentials ng contractile and conducting cells. Okay? These are found in your, primarily in your sinoatrial node. Okay? And they are what we call slow response. Tinawag lang siya slow kasi gumagamit siya ng slow calcium channels. Kung mapapansin nyo, medyo may slope siya. Hindi siya tulad ng fast kanina na diretso taas talaga ng sodium. So, tingnan, medyo may slope siya. Medyo mabagal yung pag-akyat niya. Slow calcium channels kasi ang gamit dyan. Now, sabi natin, di ba? Spontaneous yung pag-fire ng action potential ng ating pacemakers. Paano nangyari yun? So, dapat, kung spontaneous yun, automatic dapat na lumalapit yung membrane potential natin sa threshold potential. Di ba, syempre, as with everything na may potential, membrane potential, nerve, muscle, or pacemaker, pag nakarating sila ng threshold potential, mag-fire ang action potential, all or nothing yan. Once your membrane potential reaches threshold, all or nothing, mag-fire yan. Kung spontaneous ang firing ng pacemaker, dapat spontaneous din yung paglapit ng membrane potential toward that line. What causes itong spontaneous na pag-akyat ng membrane potential toward the threshold potential? That's what we call your slow influx sodium channels. What you call also as your funny, baka mabasa niyo ito sa handout, funny sodium channels. Bakit tinawag na funny sodium channels? Makinig mabuti. This is very important. These funny sodium channels, okay, are activated not by depolarization. Kasi usually, di ba, ang sodium channel natin activated by depolarization. Ang funny sodium channel natin, kasi tinawag na funny, nakakatawa daw kasi baliktad siya. My funny sodium channel is activated by hyperpolarization. Ano ba yung hyperpolarization? Di ba magiging more negative yung membrane potential? Bubukas lang daw yung funny sodium channel na yan kapag naging negative yung aking potential, yung membrane potential ko. So, di ba? Yung paglabas ng potassium, ano nangyari pag lumabas yung potassium? Potassium efflux causes repolarization, and kapag mas naging negative pa siya, it causes hyperpolarization. Kasi labas ng labas yung potassium, edi sobrang naging hyperpolarized tuloy ng membrane, naging negative 60 tuloy siya. Kapag umabot siya ng negative 60, which is hyperpolarized state, that now activates my funny sodium channels magbubukas, causing the influx of my sodium, spontaneous yan, allowing the membrane potential to reach the threshold, causing the firing of my action potential. So, spontaneous nagbubukas yung sodium channel na yan because of the hyperpolarization caused by my potassium channel efflux, causing sodium influx, causing it to hit my threshold potential, causing the spontaneous firing of my action potential. Hindi mo kailangan ng outside influence, hindi mo kailangan ng external factor to depolarize my pacemaker. Automatic nangyayari yan once my membrane is hyperpolarized. Kaya siya tinawag na funny sodium channel. Kasi pag hyperpolarized, saka siya magbubukas. Baliktad. Di ba usually yung mga sodium channel natin, lalo na sa neurons, di ba, nag-open kapag depolarized. So siya baliktad. Hyperpolarized, nag-open siya, hitting my threshold potential. Now, what will happen? I will not have an influx of sodium. I will have an influx of calcium. And this is slow. Okay? Slow influx of calcium. Okay? So, tandaan na, di ba sa nerve action potential, my upstroke right here is caused by sodium influx. Sa pacemaker, it's different. My upstroke right here is caused by calcium influx. Ang role lang ng sodium dito sa pacemaker potential is for my funny current right here. Just to generate that spontaneous, siya lang yung nag-generate ng spontaneous current that allows my pacemaker to reach my threshold potential. Yun lang yung role niya. Pero itong upstroke, this is not sodium, this is calcium. But still, my repolarization is still the efflux of my potassium. Okay? Kaya siya tinawag na, again, slow response kasi yung slope niya, di ba? Medyo may slope siya. And kasi slow yung calcium channels na ginagamit. And just to compare, again, by the way, yung numbering nito, wag kayo malilito. Ang numbering nito is right about parang same lang siya nung numbering dito. This is upstroke is phase 0. Pero since wala tayong plateau, nag-skip tayo ng plateau which is phase 2. This is already phase number 3. And this one, itong spontaneous na depolarization nung funny sodium channel, this is phase 4. So si pacemaker potential, meron lang siyang phase 0, 3, and 4. 0 being the upstroke, 3 being the repolarization, and 4 being the spontaneous current. Okay? So again, this is phase 0, phase 1, the plateau is 2, repolarization is 3, resting is 4. Ito naman, this is 0, 3, and this is, mali ito, dapat may pataas yan, ganyan, 4. Diba? So, in the interest of time, basahin na lang to, pero kitang-kita naman, di ba, yung slope nila, overshoot, etc. So, compare nyo na lang to in your free time. How do we then increase the automaticity of our pacemaker cells? What do we mean by increasing the automaticity? Diba sabi natin, spontaneous naman siya nag-generate ng action potential. Ayan, no? SAP, spontaneously generated action potential. Pero paano natin papabilisin yung pag-produce niya ng spontaneous action potential? How do we increase the automaticity? Kasi syempre, pag mas mataas yung slope niya, edi mas malapit siya. Yung spontaneous na current na yun, pag mas mataas yung slope niya, edi mas malapit din siya, mas madali niyang maabot yung threshold potential, mas automatic din siya. Ayan, no? Ito, tingnan niyo yung slope niya, mababa lang. Malayo siya sa threshold potential. Ito, slope niya mataas. Mas madali niyang nare-reach yung threshold potential right here. Di ba? So, the greater the slope, you increase the automaticity of your pacemaker cell. Tingnan niyo tong pacemaker cell na to na medyo flat yung slope niya, 60 beats per minute lang. Pero itong medyo mataas ang slope, mas mabilis lang nare-reach yung threshold potential, that's 90 beats per minute. And what can increase automaticity? Increased ang slope, ayan, no, increased phase 4 slope, increased TP. Pag sinabi natin increased threshold potential, that means more negative. Huwag kayong malilito sa signs. More negative threshold potential. Bakit mag-i-increase yung automaticity? Kasi kung ginawa mong more negative yung threshold potential, parang ganito, ginawa mo siyang more negative, edi mas malapit talaga yung resting membrane potential to threshold potential. Mas madaling mag-fire. Pero, kung ginawa mong more negative yung resting membrane potential, so ginawa mo resting membrane potential dito lang. Mas malayo siya sa threshold potential, edi hindi rin siya automatic. Okay? Kasi kailangan nga niya ma-reach yung threshold potential para maging automatic. Okay? So again, increasing the phase force slope and increasing the negativity of your threshold potential increases automaticity. Pinapalapit mo yung RMP sa TP, more automatic. Pero pag pinalayo mo, ginawa mong more negative yung RMP, ang layo niya sa threshold potential, hindi siya automatic. Okay? What are the physiologic variables that can increase automaticity? Mnemonic, CD cassette. Okay? CD cassette. Carbon dioxide, calcium, sympathetic, epinephrine, and temperature that would all increase automaticity. CD cassette. What would decrease automaticity? OA. OA. So, nag-decrease yung automaticity. OA means oxygen and acetylcholine. Okay? So, memorize nyo na lang. CD cassette increases automaticity. OA decreases automaticity. So, which of the following has greater automaticity? Anong mas mataas na slope? Sinoatrial node or AV node? Kita naman natin, ang slope ng sinoatrial node is greater. So, mas automatic siya, meaning it beats the 60 to 100. Ito ang AV node. Ilan lang ba to? I forgot. 40 to 50 something lang. So, mas na-overcome nung sinoatrial node. Yung mas automatic siya, na-overcome niya yung AV node. Siya yung predominant pacemaker natin at 60 to 100 beats per minute. Okay? Mas malaki yung slope niya. Mas steep yung slope. Paano naman kung conduction velocity? This one, conduction velocity, kanina, automaticity of pacemaker cells. Here, we're dealing with the conduction velocity of the conducting cells. Paano nila makoconduct? Paano nila matatransmit yung electricity in a faster way? Siyempre, same thing. You increase the slope of this phase zero, itong sodium influx. Ang medyo nakakalito lang dito is you increasing the amplitude, okay? Increasing the amplitude then of this phase zero also increases the conduction velocity. Ulit Pag in-increase mo yung slope, syempre, okay, mas mabilis, di ba? In-increase mo yung slope, ayan, no? Direkto from here na medyo may slope siya, naka-bend siya. Ito straight na siya. So you increase the slope, mas quick yung conduction. But also, nakaka-affect sa conduction velocity is the amplitude. The higher is this amplitude, the greater is the conduction velocity. And I think ang reason for that is, kung mataas ang amplitude nito, edi mas malaking sodium influx din yung nangyayari. So, kung mas malaking sodium influx din nangyayari, mas malakas yung depolarization. Mas mabilis kong na-transmit yung conduction, yung electricity ko, which increases my conduction velocity. So, the greater the amplitude, the faster the conduction velocity. Okay? So, ano yung physiological variables that affect my conduction velocity? Mnemonic, SIMCA over peak. So, SIMCA, sympathetic activity, and calcium, that increases my conduction velocity. Meanwhile, peak, parasympathetic, ischemia, and potassium decreases my conduction velocity. So, babagal daw. So, ano nga yung mnemonic natin for automaticity? CD cassette increases automaticity. OA decreases automaticity. For conduction velocity, SIMCA increases conduction velocity. Peak, parasympathetic, ischemia, and potassium decreases conduction velocity. So explain how the less negative RMP results in two effects in relation to automaticity. Kung less negative yung RMP ko, meaning less negative, so inakyat ko siya dito, but not beyond the threshold potential, then mas madali ko ngang ma-reach yung threshold potential. Yes, kasi mas malapit siya, mas mataas ang automaticity. But if my RMP is less negative beyond my threshold potential, so imagine nyo yung RMP ko, nandito na. Nilagpasan niya yung threshold potential. Ano ibig sabihin nun? Ano ibig sabihin nun? E di constantly naka-open yung calcium channel ko. Diba? Kung lumagpas yung RMP ko doon sa threshold potential, which activates my slow calcium channel, edi lagi naka-open yun, hindi na nakapag-relax, edi, di ba kailangan natin Contract, relax, beat, beat, beat. Normal rhythm. Kung purely opened lang yun, edi walang automatic spontaneous action potential na mapaproduce kung constantly open lang siya. And this decreases actually your automaticity. Naka-open lang siya eh. 'Di ba? Lumagpas yung RMP sa threshold potential. Okay, and that causes a decrease in my automaticity. Okay? Siyempre, kailangan mo ng spontaneous firing, 60 to 100 beats per minute. Kapag bukas lang yon, talagang hindi ka makapag-produce ng ganong rhythm. Di ba? Question 4, a 70-year-old man has a serum potassium level of 5.8. This is hyperkalemia. How might it affect the conduction velocity? Sabi natin, di ba? SIMCA increases conduction velocity. Peak, kasama doon yung K, potassium, decreases conduction velocity. Why? Kasi di ba pag may hyperkalemia, ano mangyayari sa resting membrane potential natin? My resting membrane potential will be less negative. So, sabihin natin, resting membrane potential ko ito. Ano ngayon nangyari doon sa amplitude ko ng phase 0? Lumiit yung amplitude. Kapag lumiit yung amplitude ko ng phase 0, that decreases now my conduction velocity. Okay? So I hope clear ang aking fast and slow response, conductile and pacemaker potentials. So we now proceed to retrieval practice in 5 minutes. Sige, ako na lang magsasagot nito and then watch na lang yung recording if masyadong mabilis. So, rarasyo ko lang yung mga questions natin here. Which of the following is a correct sequence of depolarization of the heart? Siyempre, we always start from the atrium and then the septum. Or mali. Dito tayo. Atrium, septum, and then we go to the apex, and then sa ventricles natin. Never mind yung PA ko. No? So, that's letter A here. Okay? Variation relationship, size of the left ventricle and positivity of the R wave in V6. Ano ba yung V6? Yan yung nasa likod, nasa mid-axillary line, di ba? One of our horizontal leads yan, di ba? So kung lumaki yung left ventricle ko, so more electrical signals will go there. Eh, di ba inline naman yung V6 ko with my left ventricle? So I will have an increase in the positivity of my R wave. Yung R wave, di ba? P, Q, R, S, T. Ito yan. So tataas daw yan, magiging ganito. Kasi kung tumaas yung size ng left ventricle ko, I will also have increased electrical signals there. My V6, which is in my mid-axillary line, in line naman yon sa mean electrical vector ko, I will have increased positivity of my R wave. Next, positivity of QRS complex in lead 1 versus lead 2. Ano nga lead 1 ko? From my right arm to my left arm. My lead 2 is from my right arm to my left leg. Alin ang mas pasok sa aking electrical vector? That would be my lead number 2. So my positivity of QRX will be at lead 2. Okay, this is B. Next, positivity of R wave in V1 and V2. Nasaan ang V1? Nasa fourth intercostal space right of the sternum. My V2 is in the left intercostal space, fourth intercostal space to the left of the sternum. So saan mas tugma ang aking mean electrical vector? Again, that's my V2. B. Next, what is the heart rate? Okay, so hanap tayo ng dark line. Wala. O, sige, ito na lang. 300, 300, 150. So between 300 and 150, probably around 200 beats per minute. Okay? Next, heart rate whose ECG shows 4 big boxes between 2 R waves. So 4 big boxes, that's 300, 150, 100, and 75. So that's 75 beats per minute. Next, distance between 2 R waves and heart rate. Kung malayo yung dalawang R waves ko, mabilis ba o mabagal ang heart rate ko? Siyempre, kung malayo yung distance niyan, edi matagal yung interval, mababa ang aking heart rate. So this is decrease. Degree of AV block and heart rate. Kung may AV block ako, hindi makadaan ng electrical signals from my atria to my ventricles. Therefore, my heart rate will also decrease. Abnormal ECG finding. Okay. P wave before QRS, normal lang yan. PR interval within 4 small boxes, normal lang yan, di ba? Within 5 dapat, tama naman. T wave is upright, yes, this is also normal. QRS occupying 1 big box, hindi. Di ba? This is already abnormal kasi dapat within 3 small boxes lang siya. Okay? Implanted pacemaker, yung may vertical, letter A. Heart rate, wag na yan. Heart block, heart block. So makakita ako ng drop beat dito. Ayun, letter D. Kita niyo yan? May drop beat, so may heart block. AVR. Ano yung lead AVR ko? Going to my right arm. So, dapat purely negative lahat ng aking tracing. Ano ba yung mga negative ko dito? A and C. Pero sa A, positive pa yung P and yung T ko. So, probably lead 3 to. Pero ito, negative ang P ko, negative ang QRS, negative ang T. Kasi nga, taliwas siya sa lahat ng mean electrical vector. That is letter C, lead AVR. Diba? Right arm yan, AVR to the right. Lead V6, that's the most positive. That's letter D. Siya yung pinakamataas, positive. Ito kasi mataas din, yes, pero may konting negative pa siya eh. Pero ito, purely positive siya. So that's lead V6. So left ventricular enlargement, meaning left axis deviation. So they left each other, ang lead 1 and lead AVF. Pataas si lead 1, pababa si lead AVF. They left each other. And that ends our session, speed session. So pagpalain kayo, I hope you remember everything na na discuss natin. So thank you very much. I hope you're able to appreciate and remember. So good luck and pagpalain. Bye-bye.